Hello, everyone. Thank you so much for joining us and welcome to Teaching Point recap session. And today we have Manaswini, Kritika, and Hans doing recap of cases from the last month. And we're very excited and so happy to have you all. And Manaswini, Kritika, and Hans, would you like to say hi to our audience? And then maybe we can get started.
Hello everyone, I'm Manaswini. Nice to meet you all. Excited for the presentation today.
Yeah, my name is Hans, same. I'm excited for the presentation. And yes, let's.
Hello everyone, I'm Kritika from India. Very excited for the session today, waiting for the learning.
Yeah, we are all also very excited. And Meta, I see your video on. Would you like to say hi and just unmute and say hi before we get started?
Hello, everyone. My name is Medha. I'm an IMG from India. It's my first time here, so I'm pretty excited. Nice to meet you all.
Welcome, and we're very excited to have you. And we just hope to see you often and maybe see you one day presenting with us as well.
And I hope so too. Thank you.
Okay, then I'll start sharing the screen.
Yeah, sounds very.
Okay. Can everybody see?
Yes, we can.
Okay, then second. Okay, I want to present a case from October 2nd. And the case presenters were Usha George. She was a physician from the Philippines. And the case discussions were Rabi and Noah. And we'll start right away. We have, for this particular presentation, two patients. And the first one is a 60-year-old male, and he presents with worsening symptoms of cough and exacerbation of rhinitis. He has no fever, no shortness of breath, and he is a lifetime non-smoker. His past medical history, however, is significant for asthma, and it was diagnosed 3 years ago. His medication included an inhaled corticosteroid, a triple inhaler, and he has been on Chinese herbs with steroids over a long period of time. So when we look at this, we have a patient who was diagnosed with asthma at the age of 57. And we know asthma is a disease, it's an allergic disease where an extrinsic trigger meets an intrinsic vulnerability. That was Rabi's explanation. So apart or outside the extrinsic trigger, the patient should be fine. But in contrast to a normal asthma patient, just to point that out, our patient, describes worsening symptoms and exacerbation of cough over a certain period of time, irrespective of any allergens. Again, asthma responds to bronchodilators and can be induced with methacholine challenge. This might have been the case in our patient. And as I mentioned before, asthma patients are in general healthy, and a change in environment does a big change. And then, of course, another important point to consider is the age of onset of our patient. And this raises the question, do we face a patient with asthma? Let's look at the physical exam. And there we have a patient, as we might expect from the herbal from China. He has Cushingoid appearance, and the herb was tainted with steroids. His exam showed a rhinosinusitis, as described by the patient, and the lung exam showed wheezes, as we would expect with asthma. Everything else is normal. His blood test, laboratory test, looked pretty much normal. We have a slightly elevated IgE level. However, a low morning cortisol of 30. And this is a high indication for the patient being on chronic steroid ingestion. And therefore, we have to critically ask ourselves, is the eosinophil count 2% genuine count, or has it been suppressed by steroids? Next would be imaging, and there we see on our chest CT bilateral consolidation. And that points more towards an alveolar disease rather than a disease of the bronchial airways, which are narrowed in asthma. The spirometry shows a moderately obstructive pattern with a forced ejection volume in 1 second of 58%. So definitely an obstructive pattern. His heart is normal. Serology showed everything normal, so no signs there for any rheumatologic diseases. Now, if we briefly reflect over the findings so far, we have chronic steroid ingestion, which suppressed the eosinophils and also led to a low morning cortisol level. Next, we have, as mentioned before, a CT scan which shows alveolar disease, which is rather unusual for asthma. And our suspicion at this point would be there must be something else but asthma. So the patient was taken off his Chinese herbal. He was put on a oral steroid with a taper. And as he tapered it off, 2 months later, he returned with another exacerbation of his disorder. A repeat lab showed a significant change. This time we have an absolute eosinophil count corroborating our suspicion of 1.4 times 10 up 9 cells per liter. So it is definitely eosinophilia with a percentage of 12%. A normal morning cortisol proves to us that his kidney or adrenals are recovering. A CT, although it showed that his first consolidation disappeared, but now he developed a new consolidation in the right middle lung and left lingual lung. So the disease is just lingering there in different areas of the lung. The serology, as before, remained unremarkable. The differential at this point would then be something else but asthma. And as I will be pointing out later at the end of this discussion, the eosinophilic granulomatosis with polyangiitis is EGPA, Krauss disease, was one of our highest suspicions. But we cannot distinguish this disease from hypereosinophilic syndrome, which can be split into 3 major parts: MHAS, LHAS, and IHAS. M for myelocytic hypereosinophilia, L for lymphocytic, oftentimes with a lymphoma, and I for idiopathic, where we do not yet know the reason where it comes from. These 3 diseases, at least the first 2, M and L, require for proof a bone marrow and further workup. On the table is also an allergic bronchopulmonary aspergillosis. We see it quite often in asthma patients. That would be independent of outside triggers, but the patient doesn't show IgE for aspergillus. With this on the background, let us now look at patient number 2. Our patient number 2 is a 65-year-old male with a history of cough and shortness of breath. So similar like the first one, and he suffered it for 2 months. The shortness of breath worsened, and he even showed up with streaks of blood in the sputum. He noticed, in addition to his hemoptysis, a rash on his fingers and his toes, and he also noticed lower extremity weakness and numbness. His gait in the meantime has become unsteady, and that has deteriorated for the last 2 weeks. He denies everything else, so no bowel and bladder symptoms, no fever, and again, he has never smoked, and he has no past medical history. His vitals are pretty much unremarkable, except for tachypnea and a high heart rate, temperature, blood pressure, and so on, unremarkable. His saturation, O2 saturation, was 92% under room air, so it shows some lung disease for sure. He has no JVD and no edema. The lung exam showed bilateral diffuse coarse crackles, heart unremarkable, extremities. There we have the bilateral lower extremity weakness, decreased sensation from the knee downward, reflexes are normal, and a vasculitic rash on fingers and toes. No rhinitis and no sinusitis, in contrast to the first patient. So now we have a vasculitic rash, we have hemoptysis, and we have mononeuritis multiplex. What is the common thing of all these three findings? And it would be, as Rabi pointed out, small vessels supplying blood to the skin, the lung, and to the nerve endings. If these are getting damaged or are inflamed, then this would impair blood flow and could explain all those symptoms. This in mind, we see that our differential could now encompass granulomatosis with polyangiitis or small vessel vasculitis in general, which is GPA, MPA, and eGPA as in the first patient. Nerve involvement, however, has never been seen in GPA and MPA, the microscopic polyangiitis. So now the next question is, what labs should we order for this patient? And in view of our first patient showing eosinophilia, an absolute eosinophil count is definitely overdue. So his hemoglobin was normal, platelets was normal, his white blood cell count was somewhat elevated, but eosinophil 31% and an absolute eosinophil count, which is very high, showed eosinophilia. His CRP was 133, which was high, and the UA was blank with a normal CR. Sputum showed no pathogens. Serology, in contrast to our first patient, showed P-ANCA. The CT scan, here we have extensive bilateral diffuse consolidation with ground glass opacities. His echo normal. Nerve conduction studies showed mixed polyneuropathy. And the diagnosis for this patient was pretty much evident from our vasculitic finding. The patient presented with eGPA complicated by diffuse alveolar hemorrhage. And the patient was P-ANCA positive. Treatment for those patients is different, and it will become clear when we look at the pathology of those diseases. Patient 2, if needed, we have to ventilate him, but not invasively, non-invasively. Pulse prednisone was not very successful with this patient, nor was cyclophosphamide. He improved on rituximab. Patient 1, after his second exacerbation, received steroids and a steroid taper. And to wean him off steroids, he received an interleukin-5 antibody. So what is eGPA and how does it evolve? This case was really interesting because it presented to us two patients at different stages of the disease. eGPA is a rare, and I would like to call this case or this presentation as a zebra in disguise because it was normal looking, but in reality, something really rare. A multisystemic inflammatory disease. It belongs, as mentioned above, to ANCA-associated vasculitides. What then could be the beginning of eGPA? We have three phases of the disease. One is the prodromal phase. It is late onset asthma in the patient, allergic rhinitis, and sinusitis. That is our patient 1. This is followed by a long 8 to 10 year period of eosinophilic driven disease development where eosinophils migrate into the pulmonary and cardiac tissue. Cardiomyopathy is one of the most morbid outcomes, which can be deadly. Eosinophils can also infiltrate gastrointestinal system, and patient shows up with diarrhea, nausea, and vomiting. The final phase is the vasculitic phase, where inflammatory processes damage small vessels, and this can lead to a palpable vasculitic purpura. Our first patient can be a glomerulonephritis, mononeuritis multiplex, basically all small vessel damage in the body. And this phase is in general ANCA positive. The pathology as such, we believe that antigens, it can be an infections, it can be allergens from the environment or drugs, they activate Th2 helper cells. And these in turn secrete interleukin-5. That was the treatment of patient 1, among other cytokines. Interleukin-5 is a known eosinopoietic substance. It activates eosinophils, causes their survival and multiplication and migration. Th2 cells also stimulate the endothelial cells to secrete eotaxin 3, a chemokine which attracts even more eosinophils. These eosinophils then can degranulate. That's what they are there for, to fight off parasites. But in this case, they damage our healthy tissue. Tissue damage in turn causes a compensatory response by the immune system to mitigate the inflammation, and granulomas form. Eosinophils also secrete interleukin-25, which then in turn increases Th2 activity, and that altogether leads to a vicious cycle. B cells, they simply add on the humoral branch of the immune system. They synthesize IgE, IgG4, which can occur as well, and ANCA. The third stage is believed to occur through upregulation of helper cells 1, T helper cell 17, which in turn recruit neutrophils to ward off bacterial and fungal infection. And that is the phase where Th2 cells kind of diminish. The patient will show an improvement of his asthma and his sinusitis and appears almost on the mend. But the activated Th2 cells, in turn with the neutrophils, cause granulomatosis, inflammation, vasculitis, and that would be our patient number 2. And that case is usually ANCA positive. So how do we diagnose EGPA? It's not that easy because we do not have a distinctive biomarker, nor do we have clear clinical features, but the sum of everything leads to a diagnosis, and this has been put in a systematic scoring mechanism by the American College of Rheumatology and European League Against Rheumatism, the ACR-EULAR. And a score of 6 and higher would then prove that the patient has Crooks-Strauss disease. And the scoring system is as follows. We need an absolute eosinophil count as in our first patient and the second one too, which is higher than 10^9 cells per liter. We should have an obstructive airway disease, +3. Our patient number 1 already has 8, which puts him above 6, so he has EGPA. That would finalize his diagnosis. Nasal polyps and sinusitis, 3. ANCA positivity points towards GPA, that gets a -3. Extravascular eosinophil predominant inflammation and mononeuritis multiplex are listed as well, somewhat lower. And hematuria is an exclusive factor. Thank you very much for your attention. And this is the literature that I had to consult. And with many thanks to everybody, that was really an interesting case presented by this physician from the Philippines, and we had the unique opportunity to see patients evolve a disease that we normally don't see. Thanks. Forget to. Hello? Stop share. Okay, now I'm back.
Thank you, Hans, for such a wonderful presentation and for covering not only one but two cases for us. And I just learned things, then I forget things, and spaced repetition is just always helpful. And Kritika and Manaswini, we are still excited for your presentations. And Kritika, would you like to go next?
Yes, sure. Sumi. And amazing discussion, Dr. Hans. I'll share my screen.
Kritika, I think you are on mute.
Can you hear me now?
Yes, now we can.
So I'll be presenting the case that was discussed on the 17th of October. It was presented by Dr. Alec and it was discussed by Dr. Rabi and Leera. So the problem representation was a 60-year-old male who presented with a progressively growing chest mass, and the patient had a history of trauma to the chest, which was 5 years back. It had developed into a small bump, and there was progressive increase in the size over the last 6 months. And there was associated loss of weight and breathing difficulty, especially in the supine position, and dysphagia to solids. So firstly, I would like to discuss the approach to chest wall mass. So we'll consider the anatomy first. So the chest wall in layers initially consists of the skin and subcutaneous tissue, followed by muscles like pectoralis major, minor, serratus anterior, and intercostals, followed by bones and cartilage, and there is pleura that is covering the lungs. So the lesions can arise primarily from any of these structures, or it can be secondarily from a metastasis or a local extension. So this is a pictorial representation of the layers of the chest wall. Coming to the history taking, firstly, we need to ask regarding the onset and progression, whether it was a gradual onset or a rapid onset, and the duration of progression over how many days or months it has progressed. And also regarding the pain, whether it was a dull aching pain or a throbbing kind of pain, or whether the lesion was painless. And we need to ask the associated systemic symptoms like fever, weight loss, and night sweats. So in this case, the patient had weight loss history. And we also need to ask a history of trauma surgery, because a hematoma or a post-surgical mass is one of the common lesions that can be observed. And coming to endemic regions, the infective focus is a very important aspect. For example, TB or any actinomycosis lesions, they can cause a sinus. And functional symptoms like restriction of breathing, movement, or neurological symptoms, if the intercostal nerves are involved, it gives a history to the precise location of the lesion. So coming to the physical examination, we first need to localize the location, whether it is in the upper chest or the lower chest, and the size, shape, and the margin of the lesions. Generally, benign lesions have a well-defined margin, whereas those that are malignant generally have an irregular margin, which are fixed. And coming to the consistency, if it is a soft consistency, firm, or a hard consistency. And mobility helps us decide whether it's a benign or a malignant lesion. The malignant lesions are generally fixed, whereas benign lesions are generally mobile over to deeper planes. And coming to tenderness, it gives an idea whether the lesion is inflammatory or not. And there might be skin changes associated with infections or malignancy, like a sinus or ulceration. And transillumination test is a very useful bedside test to rule out any cystic lesions. And regional notes help us differentiate if it is a metastasis or infection. Say, for example, in this patient, there was axillary lymphadenopathy. So that gives us a clue. And based on the etiology, I would like to classify it as congenital or developmental lesions, like dermoid cyst, epidermoid cyst, lymphangioma, hemangioma, enchondroma, or osteochondroma. And some infections or inflammatory lesions, like a tuberculosis cold abscess, actinomycosis, or the osteomyelitis of the rib or sternum. And traumatic causes like hematoma or any post-surgical seroma or a granuloma. And coming to the neoplasms, it could be benign or malignant, and this group consists the majority of the lesions. And benign tumors include a lipoma, fibroma, neurofibroma, schwannoma, chondroma, osteoma, Langerhans and histiocytosis. And malignant tumors can have primary in the location itself, or it could be a metastatic lesion. Primary lesions, the examples are sarcomas, osteosarcoma, fibrosarcoma, rhabdomyosarcoma, Ewing's sarcoma. And in this patient, the cause was a plasmacytoma. And there could also be direct invasion from the pleura or a lung carcinoma. So coming to basic laboratory investigations that we would like to ask are the workup like CBC, LFT, RFT, inflammatory markers like ESR, CRP, and tuberculin test in case of tuberculosis. Serum calcium will give us a clue regarding plasmacytoma and associated multiple myeloma. And ALP will give us idea about osteolytic lesions. And tumor markers are not specific, but they help us guide towards a particular neoplasm like carcinoembryonic antigen or a PSA. And imaging, the foremost investigation we prefer is a chest X-ray because it will help us identify any bony erosions, calcifications, rib destruction, or any pleural extension. And coming to higher investigations, we would get an ultrasound if it is a cystic or a solid lesion to differentiate the same. And in case it is a fluid-filled lesion, it helps us guide the aspiration. CT chest with contrast is a very important investigation which will help define the extent and any bone involvement or intrathoracic extension. And if it is a soft tissue involvement, MRI is a more better investigations. If the lesion has multiple metastases, then PET CT is a very important investigation. Aside from this, for diagnostic purposes, we can get even FNAC, which is a minimally invasive procedure. And for any solid or deep lesions, we prefer a core needle biopsy. If the core needle biopsy is not possible, and if the percutaneous results are not very satisfactory, we can even go for excision biopsy. And histopathology is the gold standard investigation. So this is an overview of the basic management based on the cause. So if it is any pyogenic abscess, we go for antibiotics and drainage. If it is a tuberculosis abscess, drainage if it is needed and ATT should be started. If it is a benign tumor, local excision with narrow margins. And in case of desmoid tumor, a wide excision. And NSAIDs may be considered, tamoxifen or radiotherapy for recurrence. And in case of primary malignancies, en bloc resection, if the margin is more than or equal to 4 centimeters, plus a reconstruction with mesh or muzzle flap, and adjuvant chemo or radiotherapy. For metastatic lesions, initially a systemic therapy for the tumor, and if resection is necessary, it can be done. So I would like to go back to the case. So in this, when the patient was examined, he had a large anterior chest mass which extended from the lower neck down into the chest with overlying vessels, and he had mild tenderness to touch and axillary lymphadenopathy. So this was the image of the lesion. And when we got the investigations, it revealed mild anemia and an elevated LDH. And the CT chest revealed subpectoral lobulated soft tissue mass in the mediastinum with coarse calcifications that eroded through the sternum with severe tracheal compression. And the urine protein electrophoresis was positive, and the serum light free chain assay showed a kappa level of 2000. And so a diagnosis of plasmacytoma was made. So I would like to briefly discuss about plasmacytoma. It is a rare plasma cell dyscrasia. It is generally an intermediate between the monoclonal gammopathy of undetermined significance and multiple myeloma. And it generally involves the axial skeleton or soft tissue structures. And it can be either a solitary lesion or a multiple mass without evidence of any systemic disease. So classification, like I already mentioned, it could be a solitary or a multiple lesion. So solitary further can be divided into a solitary plasmacytoma of the bone or any extramedullary plasmacytoma. In case of bone, there can be minimal or no bone marrow involvement. In case of multiple solitary plasmacytomas, there are several lytic lesions with monoclonal cell infiltrates in the extramedullary tissue. So pathophysiology, the main principal growth factor is interleukin 6. And aside from that, there might be some chromosomal abnormalities. And histopathology reveals a disinfiltrate of plasmoblastic or anaplastic plasma cells. They may be mature or immature. So this is a histopathology showing the plasma cells. And coming to the history, the patient generally presents with pain in bones with red marrow like the sternum, hip bone, etc. And there can be compression fractures of the bones. There may be infiltrating bony lesions with signs of local soft tissue involvement. And in case there is a vertebral involvement and the involvement of the nerve root, there can be associated root pains or other symptoms. And aside from this, there can also be involvement of oral cavity, tonsillar fossa, paranasal sinuses, larynx, gastrointestinal involvement. And like in this case, there can also be a pulmonary tumor with mediastinal lymphadenopathy. So investigations, laboratory investigations, important one is monoclonal proteins in the serum or the urine. Histology with biopsy or FNAC will show infiltration of monoclonal cells. Immunohistological analysis to detect CD138 and CD38 markers of plasma cells. And imaging, like we already discussed, it can be a plain chest X-ray initially, followed by higher investigations like MRI or PET-CT. And flow cytometry will help us check the degree of clonal plasma cell infiltrate. And treatment, it is a very radiosensitive tumor. So initially we prefer radiotherapy, followed by if it is a large lesion, we would like to excise the lesion. And chemotherapy is not very widely used, but if it is used, it is generally similar to multiple myeloma like bortezomib. And autologous stem cell transplantation is further treatment. Generally, it is preferred in multiple myeloma and very less preferred in plasmacytosis. So these are my references.
Thank you so much, Kritika, for making plasmacytoma so much more clear for us. And we really, really enjoyed the discussion. And we have great reviews in the comments as well. And just very grateful for your presentation. And Manaswini, we're looking forward to yours.
Hello, everyone. Superb discussion and case presentation by Dr. Hans and Kritika. I'll share mine. Is my screen visible?
Yes, it is.
I'll be presenting the teaching points recap for the case presented by UAMS residency program and was discussed by the wonderful Dr. Singh and Leera, who is here today. Really happy to have you here. Coming to the problem representation, so it is important to know who, when, what, and why, which is color-coded appropriately. And in this case, it was a 61-year-old male from South Central region of United States with chronic progressive fatigue, unintentional weight loss, and presented with a history of acute fall, and was also found to have orthostatic hypotension, oral hyperpigmentation, and gum lesions. Laboratory evaluation revealed AKI and hypercalcemia, and CT abdomen showed a calcified adrenal mass with biopsy confirming disseminated histoplasma infection. So before we proceed, I'd like to ask you all, which of the following findings do you think would be the best proxy to help you infer the time course of a patient's fall? Would it be a presence of an assisted device, or head trauma after the fall, or serum potassium levels, or a positive Romberg test? So I'll proceed with what it would be. So the presence of an assisted device will help us know whether the fall was acute or if there was a chronic reason behind the fall in the presence, because the patient might have an assisted device, showing that there may be a history of fall. So in this patient, we consider fall, weight loss, and chronic fatigue being the systemic symptoms associated with the fall. Coming to the schema of fall, so is it the external stimulus or the internal vulnerability in the patient leading to the fall? So it is important to note if there is underlying blood, neurological, or musculoskeletal problem. In patients with systemic symptoms like in ours with chronic fatigue and weight loss, we see overt systemic signs. So it's important to keep in mind syncope and also qualitative reasons like toxicology, something in or a metabolic derangement. It is also important to consider if there is no associated systemic symptoms. It is important to identify early dementia in patients, or it could be Parkinson's, which undiagnosed Parkinson's. In the physical exam in this patient, the blood pressure went from 126 over 76 to 103 over 74 after the patient stood up, and the heart rate went from 92 to 84. So we know that if the blood pressure falls more than 20 in systolic, we consider it to be orthostatic hypotension. So, what is orthostatic hypotension? We know that 500 to 800 ml of blood pools in the venous system in our lower limbs as soon as we stand up. And normally, the baroreceptors detect this fall in blood pressure because of the pooling and decrease in preload, and it increases a sympathetic reflex. And this increases the clamping and further increases the preload and the cardiac output and tries to maintain the blood pressure. But if there is a sustained reduction of systolic blood pressure of at least 20 or diastolic of 10 within 3 minutes of standing or 3 minutes of assuming a head up position of at least 60 degrees on a tilt table, we define it as orthostatic hypotension, and this was seen in our patient. It's important to know that this has nothing to do with the heart rate, although heart rate can help us localize the lesion to an extent. So, what does this mean? Also, we see a spectrum of orthostatic hypotension, which ranges from asymptomatic to lightheadedness and loss of consciousness. In our patient, we saw lightheadedness, although the most common symptom would be, the patient being asymptomatic. I'd also like to ask another question. So, which of the following do you think represents orthostatic hypotension in the heart rate and blood pressure versus the time graph? Do you think it's A, B, or C? Uh, Due to time constraints, I'd like to move forward. So I'd like to share that A and B is where we see orthostatic hypotension. So we see that the blood pressure falls. There is a sustained fall in blood pressure as soon as the tilt table is performed in A and B. But in A, we see that there is increase in heart rate, and B, there is no increase in heart rate. This suggests that A is a non-neurogenic cause, but B is a neurogenic autonomic failure. It is important to also note that dysautonomia may only present with cardiovascular symptoms and not other dysautonomic symptoms like pupillary changes in pupillary reflex or constipation and so on. It may only be cardiovascular dysautonomia. And I also wanted to share the two other graphs here, which in this graph, we see that there is sudden transient decrease in blood pressure, but the heart rate increased initially and then decreased. It's important to note that the heart rate and the blood pressure decreased at the same time, which suggests neurally mediated syncope or vasovagal syncope. And there is another condition called postural tachycardia syndrome, where there is a sudden increase in the heart rate, but the blood pressure is stable. Coming to the causes of orthostatic hypotension, so it may be neurogenic or non-neurogenic. Most common might be the non-neurogenic causes, where there is a vulnerability in the cardiovascular system, either in the vessels or in the heart. So in the vessels, maybe that the volume itself is so low in the blood vessels that even the clamping might not maintain the blood pressure, as seen in adrenal insufficiency, where there is low cortisol or aldosterone, or dehydration and blood loss. Or it may be a vulnerability in the heart with underlying mechanical and electrical causes. Or there may be postprandial dilatation of the splanchnic vessels leading to venous pooling. A very important consideration are the drugs. And coming to the neurogenic causes, where we see baroreceptor dysfunction, there may be primary neurogenic or secondary. In primary, we see that it's again divided into whether there is sympathetic or noradrenergic denervation, which may be seen in Parkinson's and so on. Or there may be the postganglionic neurons are functioning, but it's the preganglionic that might be degenerated, or in the central nervous system that may be degenerated, which is seen in MSA, or maybe also seen in dopamine beta hydroxylase deficiency or vitamin C deficiency. That would be again primary neurogenic. There may be secondary neurogenic causes like diabetes, alcoholic states, or amyloidosis, and so on. It's important to know that baroreceptor dysfunction is also seen in chronic hypertension and age-related changes. On the bedside, we can note that if there is no or little decrease in heart rate, or a simple formula, which is heart rate by systolic blood pressure lesser than 0.5, may may be a state where there is neurogenic orthostatic hypotension. And if it's more than 0.5, it may be non-neurogenic. So it's important to identify the cause, which may be drug related or volume loss or comorbidities. And in our patient, there was deranged electrolytes. And if there may be additional workup needed, like Valsalva maneuver that shows beat to beat variability in the blood pressure, or plasma norepinephrine levels after 5 minutes of standing up, which is when we expect the sympathetic system to act up. And there is a whole other fascinating world where we see peripheral non-epinephrine denervation or central degeneration, but I'll keep it concise today. And this is a Valsalva maneuver where we see that in neurogenic orthostatic hypotension, we do not see the increase in blood pressure towards the end, which is seen normally due to the lack of the sympathetic drive. So managing orthostatic hypertension would be you discontinue the exacerbating medications and make sure you increase the salt and water intake, and also modification in diet activities, diet, which to reduce or avoid high carb meals, and also compression stockings and abdominal binders. But if nothing of that works, we might need intervention of medications. Coming back to our case, we saw that there was low cortisol, low aldosterone, hyponatremia, and AKI with hypercalcemia and gum hyperpigmentation. These support adrenal insufficiency. And the CT scan showed calcified adrenal mass. So, a bit about adrenal mass before we proceed. So normally these are the adrenal glands where the arrows are pointed. And in some conditions, we see calcification. The cause may be hemorrhage, infection, tumors, and so on. In infections, there may be granulomatous like tuberculosis, histoplasmosis, or it could be hydatid disease. Now, in our patient, we saw hypercalcemia, adrenal insufficiency, and also adrenal calcification. So we might look into causes like malignancy or infiltrative diseases, which increase hypercalcemia and also cause adrenal insufficiency. But the question is, can a single radiological mass, like seen in our case, which was a single calcified adrenal mass, cause adrenal insufficiency? Maybe not. There may be possible subradiological infiltrations that were not caught in the CT due to an infiltrative disease, like such as a granulomatous disease, that might also lead to the hypercalcemia, and also due to the infiltration may have led to the adrenal insufficiency. So this increased the probability of having granulomatous diseases such as histoplasmosis high on the differential. And on biopsy, in our case, it was proved that the patient did have histoplasmosis. So the take-home points would be, when evaluating falls, it's always important to consider blood, neurologic, and musculoskeletal systems. And orthostatic hypotension can be neurogenic or non-neurogenic, but heart rate alone is not reliable to localize the lesion. And it's always important to explore the underlying mechanism. And adrenal gland calcification with insufficiency should raise suspicion of malignancy or granulomatous diseases involving the adrenal glands. And in patients from endemic regions, fungal infections such as histoplasmosis must be considered as a cause of adrenal calcification and insufficiency. These are my references. Thank you, everyone. It was a wonderful opportunity to be able to present today.
Thank you so much, Manaswini, for such a wonderful presentation. And we just really enjoyed it. And orthostatic hypotension is a very complex concept that we talked about in the academy. And now, how you just summarize it, I was impressed by Lira's discussion, and now I'm just impressed by your summary. So it was a wonderful discussion. And thank you everyone for joining us. And this was the session for today. And goodbye and have a wonderful rest of your day.